Well, welcome. Tonight, we're going to talk to some of the people that help us stay healthy. People who've been around Milford a long time can remember the little red hospital that some of us were born in and what it's grown into. And a lot of the credit goes to people you're going to meet tonight. So first thing, since we came into the studio masked and now we're socially distanced, we can take the masks off until we get up and leave. Why don't we start with an introduction?
Al, thanks for having us. I did want to correct you. I think it's not just the people in this room, it's the entire team within the Milford Regional System that works hard every day. But again, to introduce myself, Ed Kelly, President and CEO at Milford Regional, and I've been here almost 29 years.
Good evening, Al. I'm Pat McSweeney. I'm the President of Milford Regional Physician Group, the physician practice of the organization. I've been in this role for 2 years. Have been a practicing family medicine doc in the area for 25 years prior to that, and almost like lifelong Medway resident, so local guy as well.
And good evening, I'm Peter Smolowitz. I'm the Chief Medical Officer of the hospital and also a emergency physician by training. We've been working in the Boston area for about 17 years since moving from California.
So you're there with Jeff Hopkins and able to take care of the Taj Mahal Hopkins?
Absolutely. And we have a great leader in Jeff who's been a steward for the ED, the emergency department, for a while, and just blessed to be a part of it.
You know, it's amazing because you think when I grew up, it was that one little red building, you know, and tummy aches and nosebleeds, and, you know, you could do some basic procedures. Now, as we get talking, it's amazing what has been brought to Milford.
Right.
Ed, why don't we start with what is the Milford Regional Medical Center? Because I know to a lot of us there's 3 parts, and you talk about the physician's piece. Why don't you explain to everybody how you have it structured?
Sure, Al, thank you again. And maybe just to talk a little bit about our history that's important before we get into everything that's going on today, which is really unprecedented. But again, first of all, we're an independent healthcare system, which is really unusual in Massachusetts. Many community hospitals are owned by big academic medical centers or for-profits, but we're truly independent. And you know, part of that I think is our geography, just being between Boston and Worcester and Providence. When I first came to Milford, we had just started to have an affiliation with UMass, which became UMass Memorial. It's led to a number of residency and teaching programs at Milford that included, it started with internal medicine, it moved on to emergency medicine residency, and then surgical residence, and then a great deal of medical students rotate through Milford, which our attending physicians say keep everybody sharp. Later, we entered a relationship with Mass General Brigham, really the Brigham hospital system of Mass General Brigham. Again, we have physicians that kind of come out to us, but I think it led to a couple of important things. The Cancer Center, which to have Dana-Farber and Brigham and Women's Cancer Center right across the street is special. Milford Regional owns the building, and we have long-term relationships where we have Dana-Farber providing medical oncology, Brigham and Women's providing radiation oncology, and then Milford Regional providing imaging and laboratory services. And then about 6 or 7 years ago, Boston Children's Hospital came into a relationship with us. So we have one of their pediatricians in the hospital 24/7, a second one that's there based in the ED about 12 hours a day. And then we have a number of clinics that rotate through Milford, which really is so good for our community and in their families. And so I always say for a community hospital to have one academic partner is a big deal, but we have 4, and I think it's really special.
And how rare is that? I mean,
I
you're
think
always
it's
so humble about this, but when you think of a community hospital,
I think it's pretty rare, but I think, you know, one thing that community hospitals really struggle with is getting physicians to come to Milford. So we continue to have a number of private practice physicians at Milford, But really, the decision back in the early 90s to employ our own physicians in Pat's group, really, as I look back, it's debated whether, but it's probably the best thing that we ever did in terms of decisions, because it really allowed us to bring physicians through employment to Milford. And then as we developed the academic relationships, they, both from Boston and Worcester, physicians come out to our campus. And I think our mission is really, in terms of our community, it's get great local care, get it locally, it's convenient. But if you need a higher level, we have these connections to get you to Boston in Worcester. But to me, it really started back, with the group practice in employing physicians. And boy, people say it was brilliant. And I was there at the time, but honestly, it was the only way we could get physicians to come to Milford. And actually, Dr. McSweeney himself was one of the earlier physicians to join the group.
Now, when we look at it, and I don't think people really who haven't gone through it understand, I went through a bit of a nuisance 2 years ago when I went for a stress test, and I didn't pass it. Within an hour, I was in an ambulance, and I was at the Brigham to be catheterized, and the next morning or the next afternoon to go through quaternary bypass surgery. When you think about how quickly the team responded and the level of care I got, it's amazing, absolutely amazing.
And it's really, it is about the team, and really a lot of it is the physicians. Pat, I don't know if you just, kind of want to speak to your experiences.
But before you start with Pat, so you have the medical center. That's what we think of as the hospital. And
right.
Then you have another group.
Another corporation called Milford Regional Physician Group that Dr. McSweeney is the president of. And then we're going to talk later, we have a third company that's our foundation, which does our fundraising and a lot of community activity, and really has been a really important part of our expansion projects. Because when you're growing and hiring physicians and bringing in new technology, growth is a big theme, and so the fundraising and the community support has just been so important.
Now, Pat, when we think of a physicians group, why is that so important? Ed keeps talking about how that's one of the key building blocks of the medical center. Help people understand why that's so important.
Well, you mentioned earlier the excellent care and the transition from Milford into the Brigham for the care, but the vast majority of people, in their lifetime need that maybe once, but they need a lot of care that they really need to have more locally and isn't as emergent. Everybody needs a primary care doc. And I think when we sat here a couple of years ago, we were having a tough time. Our docs were all busy. Most of our practices were closed to new patients, and we were having a hard time meeting the community needs. In the past couple of years, we've been fortunate enough to bring in a lot of additional, not only primary care physicians, but specialty physicians as well as nurse practitioners and physician assistants, to the point where now, we have approximately 12 primary care providers that are accepting new patients. So, our ability to serve the entire community, I think, is much better than it was even a couple of years ago.
So in 2 years, because I remember when one of the physicians left the group, all of a sudden you're looking around saying, who is around that can be my PCP? And then you hear this word closed practice. And nobody understood why you would close a practice.
Yeah, you can only take care of so many patients. There's a limit to any business, the number of clients you can serve, if you will, and it's no different with medicine. And a few years ago, if a doc left and they had 2,000 patients, we really struggled to redistribute them within the group. We actually have 2 docs who've left us this summer, one relocating to Florida and one relocating to Virginia, and we've been able to absorb those practices amongst our group while still remaining open to patients who have not yet joined MRPG. And so I think we're in a great spot. We've been able to open some new offices or plan to open some new offices this year. We've opened an additional internal medicine office in Hopkinton just the beginning of this month with 2 internists, and they're accepting new patients. We're later this year going to open a big orthopedic office in the old Rite Aid location right up the street from the hospital on Prospect Street. It's going to have 14 exam rooms, 2 x-ray rooms. That's going to include, our 4 and soon to be 5 orthopedists within MRPG. If I may take a minute to say who they are, Drs. Mulroy, Barrett, and Vasquez were in private practice but recently joined MRPG this summer. Jeff Stoker is a newly trained at the New England Baptist joint replacement surgeon who's been with us a little over a year. He'll join them as well. And joining at the beginning of the new year is Glenn Gaby, a pediatric orthopedist who's joining us from UMass. In addition, we have 2 primary care sports medicine docs who do sports medicine orthopedics, non-operative orthopedics, if you will, who'll be practicing out of there as well. So that's going to be hopefully the place where everybody in the Milford area goes as their first stop and only stop for orthopedic care.
Sure sounds that way. My mother had 2 knees done by Dr. Mulroy, and Dr. Vasquez. Mike took care of both of my knees, so it sounds like it works.
You may be ready soon for Dr. Barrett.
And the third, just if I could finish, the third site is, believe it or not, we've already filled our 44,000 square foot building that we opened 2 or 3 years ago in Franklin, and are opening a second site in Franklin because of growth. We're adding a family medicine doc with 2 nurse practitioners and a PA, all coming from a Plainville practice, not part of the Milford system, who are now part of the Milford system.
Now, is it still like 1 or 2 PCPs that aren't part of the family? Because I remember before when we looked at it, we couldn't think of more than a couple docs that weren't part of the Milford Regional Medical Center family.
Well, maybe say it a little differently. Most PCPs now work for somebody. So mostly they work for Milford Regional Physician Group. We also have some physicians at Tri-River that are employed by UMass. And then there's Reliant Medical that employ physicians. So generally it's employed physicians in some
Why?
corporation.
Is it the cost of technology, or?
Yeah, I think one recent reason, fairly recent I guess, is the cost of an integrated electronic health record, or EMR. A private practice really can't afford to do that. I think that's one, and it's I think a dying breed, the private practitioner. The amount of time it takes to practice medicine, and then if you add on top of that to be a practice manager, a business manager, a billing manager, et cetera, it's just too much. So, I think you're going to see big private groups or big employed groups. I think the solo doc, the small group, I think is kind of going away.
Well, I know it's convenient as a patient because I don't have to do anything. I go into any of the people that are taking care of me, and they have access to all my records. It's scary sometimes, but they know everything. My meds, everything is all at their fingertips. That's got to be a huge benefit.
Absolutely. When your specialist and your primary care doctor work for the same group and they have all that information on you, it's easier for you. You don't have to repeat all that information. It's easier for your providers that they're able to share information. It's better care. I mean, there's lots of evidence that integrated care is better. That's why there's, one of the reasons there's been the promotion of integrated electronic health records.
Well, I remember when you were going through the upgrade, a couple $100 you had to pay for that new system. It was amazing how much that was.
Yeah.
When you start talking about millions of dollars to upgrade.
Right.
I mean, how could you expect one physician or 2 to bear that burden?
Right.
Now, let's talk about the topic that is on everybody's mind, COVID-19. What's happening in Milford as far as COVID-19?
I wish it's a topic we didn't still have to talk about, but obviously it's one that's still front and center on everyone's minds. Things are tough, no doubt, right? I mean, the Delta variant was unexpected, but in some ways, the development of these variants is not surprising. But it has been spreading rapidly and now accounts for, I think, like 99% of cases of COVID-19 throughout the United States. It no doubt or undoubtedly has had an impact in this local area and across Massachusetts. I guess the one silver lining is that because we have such a high percentage of people here that are vaccinated, we are seeing less of an impact than many of the other states where there's really hot spots of COVID-19 activity, and their hospitals are absolutely being crushed under the weight of patients who need care. That's not to underestimate just the impact of COVID-19 on any single individual here who is suffering from that. But thankfully for us as a system and in a state, the relative weight of this compared to other states has been less so, but still impactful. And this, most recently, we're having, patients that are presenting to the hospital with COVID-19, but also, as people may have even seen, the hospitals across the state are being inundated with patients who need health care for other reasons. And the causes of that isn't entirely clear. Some of that may even be pent-up demand from things people were putting off for some time. But hospitals across the state of Massachusetts are struggling both because of COVID-19, the volume of patients from non-COVID conditions, and staffing shortages across the board.
Well, you've got to run a pretty lean operation to begin with in today's cost structure. So it's not like you got 30-40% open capacity.
Right. I think business-wise, Al, we're not even thinking of I think that historically you want to stay in business. Right now, we're in survival mode to take care of our community. And I think it may be helpful just to look at COVID in terms of the three kind of phases. So the first phase was basically everybody was in kind of lockdown at home. And at the hospital, we had kind of a peak of 40 really sick, generally elderly patients that really were consuming a lot of health care. And everything kind of elective was really shut down. And ironically, from what we might have initially anticipated, the ER was like a ghost town. The second phase was younger people still sick with COVID up to like an inpatient capacity of ballpark of 60 patients. But in the hospital quicker, again, not as sick. And again, I'm oversimplifying that because it was a tremendous, burden to take care of the community, and really a credit to all of our staff, from physicians to nurses to ancillary staff. It really took the team effort. But just to kind of fast forward to where we are right now, and again, for me, just to generalize, and these two doctors can kind of fill in, but from my perspective, the hospital is on overload, but it's, again, largely not related to COVID. COVID does complicate things. So I would say we're generally less than 10 inpatients, but unfortunately, it's been a much higher percentage of unvaccinated patients that are really sick, and unfortunately, some younger patients in their 30s, really super sick. So that's completely different than the first two phases. And then again, heavy outpatient burden of people that are sick, but not, they're largely vaccinated and not nearly as sick as before, but still very taxing to the emergency department that's over capacity, as well as the urgent care. And I've been hearing loud and clear in terms of the physician practice, what this has done on the outpatient side. So this third phase is really, our system is maxed out everywhere, and largely the state is maxed out. And Pat, maybe you just want to speak about what you're seeing.
Well, Pat, before you get started, to vax or not to vax? Why is that still a question?
I'm not sure I can answer that part of the question, because I think from the scientific perspective, there's no doubt. A lot of things in science are uncertain, but in my mind and in the minds of every single medical expert, the question of whether to vaccinate against COVID-19 is one that's been answered. At this point in time, we absolutely know without a doubt that the vaccines are both safe and effective.
Well, couldn't we say that we've gone through the biggest clinical trial known to man?
You stole the words right out of my mouth, Al. Yeah, I mean, at this point in time, we've had hundreds of millions of people.
130 million person clinical trial.
Never been one this big before.
Exactly. I mean, when they started saying it's being released, I sat there and I said, when I think of all the clinical trials I've been involved with, nothing this close. And then when people say they don't want their family vaccinated, well, when we were children, weren't we all vaccinated with the mumps, rubella, the measles? So it's not like this is a new thing of vaccinating people.
It is true that there's been an absolute concerted campaign of misinformation out there. And you can see that on social media and cable news, that people are intentionally spreading misinformation. And I think, for the community here, I would encourage people to ignore that information and really focus on the scientific experts and let us be your guides for this.
And again, I just want to compliment both of these physicians in their in the team of medical staff at the hospital, because we've tried to make this about the science, and both of them have spent a lot of time trying to work with, many employees and community members that really are trying to get the right information. Again, I think we've gotten great feedback about what they've had to say with regards to, the science about the vaccine.
Well, the thing that's scary is when politicians start assuming the role. I mean, Ed, there's a line here. There's MDs and there's not MDs.
Right.
You know what I mean? And I sit there and I say, wait a minute. If I'm going to take medical advice, nothing against you or me, but that side of the line is who I should listen to. Otherwise, you spent half your life learning and not having a benefit of it. You sit there and say, you spend half your life learning to be a physician. I hope that I can trust your knowledge more than ours. And I just don't understand why people have this anti-vax idea.
Al, I don't think you're going to get an answer from us on that, because I don't think we understand it either. I think it's, in a lot of ways, it's very simple just looking at our country. If you look at the Northeast, where vaccination rates are high, comparatively speaking, hospitals are not at capacity or over capacity with COVID-19 patients. In the South, where vaccination rates are half what they are up here, hospitals are overrun, ICUs are overrun, ventilators are at full capacity, full use, because people are not vaccinated down there. That's the evidence. That's the only evidence you need if you look at it objectively, in my opinion.
Now, I'm feeling sick. Today's trend. Do I go down to the outpatient care, or do I go to my physician?
Urgent care?
Urgent care?
No, I would ask today that you call your doctor and get advice. As Ed was mentioning earlier, fortunately, our hospitals are not at capacity and overrun with COVID-19 sick inpatients, but our urgent care clinics are. We're seeing probably the same volume of urgent care visits now as we were seeing in the height of the winter, when there were 60 patients in the hospital with COVID, and we were seeing incredibly high numbers in the outpatient setting as well. We're seeing those same numbers in the outpatient setting. They're not as sick because a higher percentage are vaccinated, but our urgent cares are overrun. So we're trying to do better with testing options for our primary care docs to send patients to, doing some more telehealth to lower risk of exposure to potentially sick patients for our staff and providers, as well as trying to educate our staff and providers as well, that compared to 6 months or 9 months ago, it's much safer for even those sick patients to come into our offices, because all of our staff, or most of our staff, and soon to be all of our staff, will be vaccinated. Our PPE status is better. There's no shortage of PPE at all. We've learned how to social distance. We've learned how to get patients through the system with as little exposure to other people. So for all those reasons, we're in a better place to take care of our patients other than just in urgent care. In the winter, when we were sending all our sick patients to urgent care, we were trying to really kind of cohort them in one place to slow the spread. Well, if you're vaccinated and masked, the spread is very low. So we feel that for that population of patients, we can start seeing them a little bit more. So again, go back to your question, as of this week, I would say call your primary care doctor first. Depending on your symptoms, they may send you to urgent care. They may say, hey, let's get on a video telehealth visit and review your symptoms, and I'll decide whether you need testing or not, or whether I need to see you to listen to your lungs or examine you. But that would be my advice. Call your primary care doctor first. They're ready to send you in the right direction.
If they send me to urgent care, how scared am I to go there and be amongst all these sick people?
I would say no, not because we're not jamming you into a crowded waiting room where we're social distancing like we are now in our waiting rooms. And if we're over capacity and we can't directly put you in a room, we'll have you wait in your car and take your cell phone.
I was going to say, my PCP, when I was going to Hopkinton, to the office in Hopkinton, they gave me a phone number. I called from the car and said, I'm here. And then they said, okay, we'll call you back when it's safe for you to come up.
And hopefully you're vaccinated and have a mask on.
Well, that was
Well,
the first questions that came out. Are you double vaccinated?
Yep.
Do you have your mask with you?
Yep. So no one gets inside our door without a mask on, and they wear their mask the entire time. And if they have a homemade or cloth mask, we give them a surgical procedure mask, which best evidence says they're more effective. If we can get you into a room right away without waiting in a waiting room, we do that. We can do the talking portion of the visit even through cell phones on the other side of the doors. If
Yes,
we
I
need
got
to.
screened in my car.
Yep. So, there's ways to limit. So no, I think if you feel like you need to go to urgent care, you should feel very comfortable that it's going to be a safe place for you. It's safer than going to the supermarket or anywhere else.
Now, from a technical point of view, we're hearing that New England is a safer place because we have a higher vaccination rate. But that there's some crossover, I guess is the word, or I've been double vaccinated, but I got the Delta variant anyway. How prevalent is that?
I think I would look at the question a different way, Al, which is no vaccine is intended to be perfect against infection. So I don't even call them breakthrough infections anymore. I just call it that people develop COVID-19 even though they have been vaccinated. Obviously, the chance that you become infected when you have been vaccinated, even with the Delta variant, is much lower than if you've been unvaccinated. But most importantly, that's not really the target, is whether you get an infection or not. But the vaccinations are remarkably effective, probably more than almost any other vaccine in history, at preventing people from being sick, hospitalized, and dying. So I think we have to keep our eye on what the goal of these vaccines is. None of them can be perfectly effective. And even against the Delta variant, we are seeing remarkable effectiveness in preventing people from being really ill. So that would be the take-home message for me is people should still get the vaccine, even with concern about the Delta variant. We're going to see cases happen, but it's going to keep people safe.
Now, again, dumb question from a non-medical person. I'm reading how people are scared to take this new vaccine, but they're going to get their flu shot. Am I missing something here? Isn't the flu shot the same principle?
Well, I think one of the keys is there are different kinds of COVID vaccines, right? And one of the vaccines, or two of them, the Pfizer vaccine and the Moderna vaccine, is a platform which is relatively new in terms of the use or the spread of this vaccine, so they're called the mRNA vaccines. But they're not new. They've been in development and in the workings for decades and decades and used in other types of vaccines, like against Ebola. But when things are relatively new in terms of how people are receiving them, there's always this uncertainty. But again, I would go back to just what you said before, is we've had almost the best randomized control trial in history at this point in time. These vaccines are remarkably safe. And if you look at the science of them, it's a beautiful thing at how these mRNA vaccines work and deliver this right into the cell, allowing the body to produce a really robust response against the proteins for the virus.
I remember when H1N1 came out, and Mike Newstein came. And again, I asked a dumb question from a layman's point of view. Isn't it mainly wash your hands? And he said, yes, treat H1N1 just like any other virus, and you'll be better off. It won't be perfect. But, again, I think of every year we have, is it 3 strains on the flu virus? And you knock one out, you put the next one in that you believe will be the hot one. So every year we're dealing with variants. So when all of a sudden people started saying, oh my God, it's mutating, I sat there and said, well, don't I deal with that every year?
Al, if I could play your role for just a minute. When I get a question, even though I may have a sense of what the answer is, I try to defer to, to the medical experts. So sometimes, the questions that come either directly or indirectly is, hey, I've had COVID, do I really need to get vaccinated? And again, I would defer that to Dr. Smolowitz, and maybe, Peter, just someone in the audience is thinking that. So maybe just a comment on that?
Yeah, it's a great point, because it's a common question we get. And actually, you talked about Dr. Newstein. He and I discuss this on an almost daily basis, and I take his guidance on a lot of these things, so I give him a lot of credit. But one of the common questions is, I've already had COVID. Why do I need to get a vaccine? I've read somewhere people say that, I'm already sufficiently immune, so I don't need the vaccine. And in fact, that's just completely not true. And we know, and we have definite data, that getting the vaccine on top of getting the natural immunity from COVID-19 is far better immunity. And that's been demonstrated in a number of studies. It's almost like I've heard it referred to in some places almost like a superpower of having much more effective immunity against both infectiousness and severe disease when you get the vaccine, even if you've had a previous infection. So there's really no doubt that should happen at this point.
Follow-up question. I got vaccinated January. It's now September. Do I still have immunity? I mean, they're talking about the booster and all. What's the story there?
The shorter answer is, I don't know that we have one definite answer, but I can tell you what some of the experts have been saying on this topic, which is it's almost anticipated that some of the immunity over this would wane, and that people will need a booster. I've heard Dr. Fauci most recently say that if one were to have devised this vaccine in the quote-unquote right way, it would have been getting one right away, one a month later, and then one 6 to 8 months later. Because almost getting one at a month, while we needed to do that for the urgency of revving up the immune system, wasn't enough time to prime the body's immune system towards an infection that might come later on. So we know that we can't measure it just by your antibody levels, because the immune system is much more complicated. We also know that it's just natural that immunity is going to wane over time. So I think at this point, most of the experts are agreeing that it will be likely that people will need a booster, roughly 8 months after their initial set. Whether that means we're going to need one every year, I think still remains to be seen after that.
But is this along the lines of, I'm getting an IgM immediate response and then I'm building the titer for IgGs? Is that what you're looking at?
Probably is a little bit more complicated than that, Al, but but I would say is the antibodies are just part of the response. And we know that measuring your antibody levels, which some people are like, can I just get a test that shows me how immune I am? That's not the answer. The immune system is more complicated, has a memory response. And we know that both the memory cells and then the T cells, which is another part of the immune system, are really part of the body's way of revving up to seeing an infection later on when it hasn't seen it in a while.
Another question. Is there any downside to getting a booster or a third shot?
Did you have something you want to say first?
No, I got another question teed up. No, go ahead, you can answer that one.
I don't know that there's a way to answer that with respect to just the booster. The same reason people wouldn't get a booster is why they wouldn't get a vaccine to begin with, which is few and far between. For example, immunosuppressed patients are the ones that most likely need to get this and most need the vaccine to begin with. People who have had a severe or anaphylactic reaction to one of the COVID-19 vaccines shouldn't get that one again. Other than that, I can't really think of any great reasons why there's a downside at all to getting the booster. It's just that we still don't have certainty over how effective it is. But I'll continue to watch the evidence for that as science changes.
The other question sometimes we get is for pregnancy, and again, I defer that question to Peter.
Yeah, we have. This is another great question that we've vetted carefully with kind of our medical team as well as our chair of obstetrics and gynecology. And really the American College of Obstetrics and Gynecology, which is kind of the preeminent group that develops the clinical rules and guidelines for pregnancy, are fully in support of the vaccine during pregnancy. Basically from the time someone becomes pregnant till the end of the 3rd trimester. What we have decided as a hospital is we're giving people a deferral through the 1st trimester, partly just so they can have an informed discussion with their obstetrician. But we want people to get vaccinated, and anybody after 1st trimester, we believe firmly should be vaccinated. And there's definitely safe evidence to show that that's safe and effective.
Next question then. Is there a difference?
They all going to come to me on
That's
that
all
one?
my questions, yeah.
We're going to have Pat answer some of these hard ones.
Well, you've got 3 different vaccines. Any scientific evidence that blue, green, or red should be chosen?
You want to take a stab? Or you want me to go with that one too?
No, you go ahead. You're fine.
I'm going to roll with the vaccines. No, I mean there's definitely evidence that all of the ones that we have here, the 2 mRNA vaccines and the Johnson & Johnson or Janssen vaccine, are all very safe. They're all very effective. There is some potential signal of a very rare side effect of these thromboses or blood clots in women specifically of childbearing age for the Johnson & Johnson vaccine. So I guess the one thing that I might keep an eye on is for a woman of childbearing age to potentially preferably receive one of the mRNA vaccines instead of the J&J vaccine. Other than that, I think it's just a matter of which one people have access to.
Yeah, we spent a lot of time talking about vaccine, and appropriately so, but I don't want to let the opportunity pass to talk about masking as well. I think we were too quick to shed our masks, and in retrospect, we're learning that by the surge that there is now. So masks are an important component of preventing spread. So really, I think, although not mandated, I think it should be strongly encouraged that anyone, vaccinated or not, in any indoor places, especially indoor crowded places, should be wearing masks. And so I would encourage everyone to do that. And that and vaccine are the 2 strongest weapons we have against COVID.
Well, Tony Fauci, good Holy Cross boy, I got to listen to him, drove into me, the idea of it's safer to wear a mask than not to. Period. End of story. It's uncomfortable, but that's the only downside I could hear out of his mouth, to say wear a mask or don't. And then washing your hands or using, hand lotion to clean your hands after you're in public places. I mean, all of those just seem something we should have been done for the beginning to the end. And once the pandemic is over, the new strain of flu will come in and we should still do it. Am I wrong?
Well, I guess I would just support what Pat says, specifically with respect to masking. And I think this comes up now with parents worried about their kids wearing masks in school or being uncomfortable wearing them. And I would just say, one of the things you do well is you simplify the way we talk about things. And I've heard it talked about that kids have a much easier time of wearing a mask than being hospitalized. And wearing a mask is far easier than getting gravely ill or dying. It's that simple.
Another question. Why is it that the vaccine is not being given to small children?
Well, the simple answer, it hasn't been approved yet for use, and not even for the emergency use authorization. But I have heard in the lay press that we anticipate that the studies, at least starting with Pfizer, should be available for review by the FDA fairly soon, even sometime in September, which could lead to children between 5 and 11 being offered the vaccine later in the fall. That would be wonderful if that happens.
So if my understanding's correct, it's not that they're worried that there's data out there that's negative. It's just they haven't had any data reviewed for kids yet.
Yeah, it was the last, looking at all the vaccine studies, kids were the last ones to be involved in the studies after the adults, went through the careful studies. And you're right. I think we don't want people to look at it and say like they're just worried about some signal of safety out there and that's why they're not moving forward. That's not the case. It's just that they have to complete the studies, be very cautious and careful. And also keep in mind that they had to do some They had to make some judgments about the dosing of the vaccine, which is different for the kids.
And I wanted to come back to, we've hit on the vaccines, masking, but and it may in some ways sound like everything is under control, and I think healthcare in general throughout the state is just treading water, just because of right now it's a small mix of COVID compared to the rest of the country, but just systems are under a lot of pressure of sort of care that's been delayed. But I think in terms of staffing of businesses in general, from restaurants to any business, it's hard to find staff. And some of it's COVID and kids being at home. It's also people are exhausted in general. So people that might be part-time that would work more are not working it. And then there's the family leave that just started in Massachusetts this year. And so for me, as I walk around every day, whether it's at the hospital or in the physician practices, it's really, a heroic effort of all of our staff. So we talk a lot about medical staff and where they come from, and we're very fortunate to have the great medical staff that we have and the connections to our academic partners. But really every day in the trenches, it's the nurses, the folks in imaging, in laboratory, respiratory, it's the whole team. Our physical therapist on the outpatient side, our food service workers, our environmental care, it's the whole team. And really, finding staff to manage all of this has not been easy. And so there's basically, again, I make the comparison to sports. I mean, it's really been a team effort across the board to get us to this point. And that is why, like, when you see systems overwhelmed, sometimes in other parts of the country, there's just like no room in the inn. But staffing is a component. It's just not how many beds do you have open. It's can you staff them all? And so it's been a real struggle. So for me, in addition to talking about COVID itself, I want to recognize, the effort throughout our team that's just been, so supportive in getting us to this point. And hopefully there's life at the end, with vaccines and what's coming and hopefully good compliance, that things will get back together soon.
Well, I've heard the medical unit compared to an aircraft carrier. We all look at the jet pilots. But if somebody forgot to put gas in their jet or didn't put bombs under them, not so good results. And when you start thinking about 300-400 jet pilots out of 4,800 people on an aircraft carrier, kind of reminds me of your medical system.
It's true.
There's 300 or 400 pilots, but there's 4,500 people to make sure that they're ready to go. Now, put you on the spot. Why do you get to keep so many people? I mean, you hear people turning and leaving and moving around, yet when we go to Milford Medical, the regional medical center, there's people there for 20, 30 years.
Yeah, so we have our mix. I think it's the culture at Milford. It's the people that work there. It's one of those things, again, comparing to sports, that if you've got a good team, it's easier to recruit into the team and it's easier to keep the team. But it's not easy, and I think, sometimes at any level, folks want to go to the city, and we see that. I think, as Pat mentioned, in terms of the physicians, we lost a couple of physicians this year, but they didn't go to the next town. They went to, they went out of state. Again, I can't credit just one thing. I think the core is that we provide really good care at Milford, and luckily we've been able to support like all of the technology that's needed. So I think for people that practice medicine, no matter what their level, that is really important. Liking coming to work every day, a commitment that we're going to do the best we can to take care of our patients and our community. So I think it's a lot of intangibles that make Milford a special place. And certainly COVID has been a challenge, because some days, when you go down to the emergency room and there's 75 patients and we got 50 beds, it's not fun. but there's a job to be done, and again, it's a credit to the team in terms of making it happen. So.
And Al, if you don't mind, just to add on to that really quick, because I think it's important to emphasize, to go back to both of what your analogies were. If you were on that aircraft carrier or on that sports field for a year and a half straight, every single day, hour after hour without a break, how do you think you'd feel?
Yeah.
And I think I want people to know that our providers, our clinical and non-clinical staff are exhausted. And they've been at this for a year and a half straight, just focusing on working as a team and getting the job done. So, I know we try to say this all the time, but they should know how thankful we are for them. And I would encourage the community to also reach out to them and thank them for the job they do every single day.
And what can the community do to thank? What's the number one thing that the community can do to show their appreciation?
Get vaccinated.
Get vaccinated and wear masks. Absolutely.
I was just saying, not
We
get
didn't
sick.
plan that.
Right. No, that's a good point. And I want to take a second to echo a couple of things Ed said. The culture is part of the reason, and it maybe sound a little hokey, but it's true. My first 5 years in practice, I practiced in this area for 25 years, 20 of them as part of Milford Regional Physician Group and its predecessor named Tri-County. But first 5 years were elsewhere, and I still remember vividly the first day I came to work in the hospital, because back then, family medicine docs and primary care docs saw their patients in the hospital too. I just remember it was a different place from the place I was the week before. Just an overall atmosphere, the teamwork, physicians and nurses and nursing assistants and unit secretaries and radiology techs, just working well together. And again, it was now, I don't know, 22 years ago almost, and I can remember it like it was yesterday, because it was so overwhelming to me, the difference between the two places. And is it exactly that way today? No, but no place is. And the fact that we're still kind of holding together is because of that foundation, and it's been there for the 20 plus years I've been
Well,
here.
60 years ago, all of Milford could trace their lineage to 4 docs. Cicchetti, Mastriani, I can name them. Because there was only 4, and one of them brought you into the world, and more than once threatened to take me out of it if I didn't behave. And now you start looking at what's available in Milford. It's amazing. We've talked before, when my sainted mother got cancer, it meant so much to her to be able to just drive down the street. We weren't in a car for 2 hours fighting traffic, having her tension level go up. And then month after month, year after year, she would say, I go see Dr. Mona. And there was the same face. And there was a level, probably not needed, because all the physicians would give excellent care, but to an 80-year-old lady, seeing the same face every time, going to the same place every time, certainly in my mind made compliance easier. Now, something we normally don't do on the show is let people have commercials, but I think it's critical, because people don't know where to go to get primary care physicians. They move to Milford, and that's usually the first question. Is where can I get pediatric care, and where do I go for my primary care? Why don't you answer that question?
Yeah, thanks, Al. It's very simple. MilfordRegionalPhysicians.org. Homepage, list of all our primary care doctors who are taking new patients. And again, there's at least 12 of them now.
And they're open. When we say closed practice, that means that they have so many patients they can't give quality care to anymore.
Right.
So they don't take on any. It's not like a
They-
bad thing.
Right. They don't. Right. They want to give you the attention that you need, and they don't want to do a disservice to you or anyone else. So we say, okay, that's the limit. You can't do anymore.
Yeah, we have a
Things
quality
will
level
suffer,
that we're going to
Yep,
maintain.
something will suffer if you. Right. So and it's different for different docs, different types of practices. But right now, there are at least 12 providers, docs, or physicians or nurse practitioners or PAs that can take you as their primary care patient, and they can see you hopefully within a few weeks or even sooner if it's an urgent problem.
And we'll ask our director, Brent, to put up that website as the credits roll so that people can go. But I mean, realistically, if you're old like me and your memory goes away, you could just call the medical center and say, I need to contact somebody to get a primary care.
Yeah.
I would imagine they'll be able to tell you how to call
Yeah.
somebody.
We have
So-
a physician referral line.
Yeah,
as
but
well.
we also, I wish this were a couple of weeks later, because we've just hired a new patient coordinator. And we're gonna have one number. I wish I could tell you the number, but it's, it's 3 digits and then get MRPG is the phone number. And you can call that number, any patient, anybody who's looking to refer someone, and they'll be your sort of personal guide to primary care or any of our specialty care within the group.
So the first 25 years, you did pretty good, Ed.
Yeah.
What's coming up?
Well, I just wanted to take 1 second, Al. We've thanked a lot of groups tonight appropriately. One group we haven't thanked is the community. Again, I think having been here almost 29 years, we've had a lot of projects along the way. And, the community has always been, in many cases, half of the support of the project. And the biggest one was the Me and Family Pavilion, which opened in 2015, where we went from like 17 ER rooms to 50. And you just think about, where would we be today?
Can you imagine if you hadn't built it?
If we hadn't built it. And it wasn't that easy to build. And I think you remember the story, but we had 3 options. And we went, we had, the biggest option was 50 million, and people laughed and said, we can't afford that. And Kevin Meehan said, that's what you need. And you need to fundraise half of it, and I'll give you 5 million, but you got to raise 25 million. And it happened. And thank goodness today that's where we are. But that's a lead into, so, believe it or not, in many areas now, I think because of COVID, we've put this off, but it seems like every few years, we have to think about what's next. And so we are thinking about that. We don't have any plans, but in a number of areas, we are starting to get to capacity. So the footprint is pretty tight around the hospital. We have that space across the street from the hospital, but we really don't have any specific plans. But even once you develop a plan, it takes a couple of years to implement them. So we are starting that process of thinking about what's next, because again, from some imaging areas to some inpatient areas to some ancillary areas, we are getting a little tight. Pat's been too successful at recruiting that we've got to kind of step up our next kind of strategic plan there.
But you start thinking about the hospital, the clinical part, and you think about the physicians. But you've got a third part of the triad that's very important too. Because if we hadn't raised, if Emily and crew didn't raise $20-some million, how would we have done the ER?
Yeah, we wouldn't have done it. Yeah, I mean, we had that sense and the commitment that we could do that before we built it. So that was necessary to getting the financing. So again, it was kind of great leadership of community members, business people that said that's what you need. And again, fortunately, we did it. So,
But part of it is self-serving. When I give money to the foundation, I'm really giving it to me, because I'm investing in a resource that hopefully I'll never use, but I know I will. And like I said, when I failed that stress test, it was comforting to know that I was on autopilot. I don't know what was happening, but zoom. Next thing I'm in the Brigham, I'm all pre-registered, I'm ready to be harpooned, and off I go. I mean, that's very, very comforting to know. But again, it costs money. So when, people see things like Melange, that's got to be the premier black tie affair in the area.
it is.
It is a wonderful event. And I know that the foundation staff are struggling on how to pull it off, should they.
And whether we could, right? Yeah.
Should
So,
they,
yeah.
and I know when I got the call, I said, if you can do it safely, yes. Because that's 600,000 to $1 million. Again, it's an investment in our future.
It's true.
So hats off to the third part of the triad. What do you think is the biggest challenge coming up for you?
Well, I'd say in the short term, it's the staffing issue, because I don't see the end to that. I don't think we completely understand. Is it COVID fear that people were close to retirement said, okay, I'm getting out now because it's too risky? Is it the unemployment benefits? Is it the FMLA? What is it? So until we understand what the cause is, it's hard to fix it. And we can have all the patient demand and we can have all the physicians, but if we don't have the support staff, we can't do our job. We can't keep that aircraft carrier going in the right direction. So, that's in the short run. But I think in the long run, the challenge is to continue to grow. I mean, we've done well in the last couple of years where we're kind of expanding our market. We're trying to get to the edges of our market a little bit more, but I think the challenge is going to be to continue to do that and capture more of the business, get more people to understand that they can get 95% of the care they'll ever need locally. And we need to continue to capture more and more of that business.
And from our clinical technical area, what do you see as the biggest challenges?
That's a tough question to answer. I mean, there's a lot of challenges that are facing us. I think for me personally, it's balancing the challenges we face and the uncertainties over what the future for COVID looks like, along with all of the other really wonderful things we have planned for the hospital and the ways that we continue to grow and serve the community. And I guess the other piece that I really focus on every day is, as we talked about before, trying to make sure that the clinicians in the hospital feel supported, because this is a tough time for them, that they feel supported, that they feel they have the resources they need to do their job, and that they feel safe and can provide the best care and evidence-based care for all of our patients.
And Ed, you're at the helm.
Yeah, and I think Peter said it really well. I think over my 29 years, I've been used to people really stepping up, but the duration that we have right now, and when it's going to break, and how do we transition to that new normal is, it's hard to kind of figure out exactly how that is going to happen. For me, going back to when I first started here, and I'm very influenced by where I've worked before. I think the thing about Milford that we've done, there's been a little bit of a leap of faith. Just continue to take good care of patients. So whatever a community hospital should do is what we want to do. And the good news is like we can do more. So part of it is, patient demand, physician demand. We want to do more locally, but you can't change that overnight. And so our mission of continuing to provide great local care for our community, have that benefit to say, hey, I'm just going to go locally here. And I know that if they can't handle it here, they're going to make me these connections to these great academic centers. So it's just continuing to keep that go, and how do we transition from this unprecedented time. So,
well, thank you for everything you've done. Thank you for everything you will keep doing. We hope to have these conversations more frequently, but about better topics than COVID. But from an old man, my sincere thanks for what you've done and what you've accomplished. I saw it with my mom being treated the way she was. I saw it when I had my nuisance and had to have that bypass surgery. Made it a lot easier to trust, to have it done so efficiently. And to our 6 loyal viewers, it's amazing what we have here at the center of the universe. I hope you never have to use it, but when you do, take it from somebody who's been there twice now, with my mother and myself. You're in good hands. So as always, thanks for joining. May God bless. May tomorrow be a safer and healthier night. And we're back to masks as we're going to leave the studio. Good night, all.
thank you.
Not too long since I've been home. Been running all my life just